Hmm. I'll give you another case, my friend. Let's see. I want to just remember this one.
Mm,
Okay.
mm,
You can start, yeah, boss. Ask for
mhm.
control. Hmm.
How do I ask for control?
Headache
Mm,
and fever. By the way, in the
uh-huh.
exam, if you faced a difficult case in the start, no problem. Stay concentrating,
Calm.
stay calm. Okay? It may happen.
Okay.
We have
Yep.
three cases with each examiner. Maybe we're starting with a difficult case. No problem. Forget
Mm-hmm.
about this one. Follow
Mm-hmm.
stop and another line. Okay?
Sure, sure.
Uh,
Um, Doctor, I can't
control.
see the control button. I can't find
اوكي
it.
what is your name يا بص.
ريم سلمان.
ماشي يا دكتور، حاضر. ازيك يا دكتور ريم؟
ازي حضرتك؟
اوكي، اهلا بيك.
الله
I'm
يخليك.
wait okay R E
Mhm.
I
Oh, I'm
can't
really
find
sorry.
you.
I will change. Find. I mean, you can scroll for me if this is
Okay,
faster,
I
but
will
I'll.
scroll. I will scroll. Okay.
So
Okay, no
I'm
problem.
sorry. I don't want
تعبان
to
يا
waste
دكتور.
everyone's time. لا لا. I'm
No problem.
sorry.
No
I don't
problem.
want to
No
waste
problem.
everyone's time.
لا لا, no problem.
Um.
Okay,
Yes.
what do you see again? The history. We have some headache and generally unwell or septic fever.
In this axial non-contrast CT head, I appreciate that there is opacification of the paranasal sinuses as well as the
Good.
right ethmoidal sinus. There is no there and the frontal sinuses as well.
Good.
I also saw a hypodense lesion in the right frontal lobe, surrounded by a hyperdense. If we go a few slices up,
Good. Good.
uh,
Hypodenuse in the frontal lobe and
yes, and this seems to be continuous with the frontal sinuses. I also would like to just have another run through the venous sinuses to see if there is any hyperdensity in the venous sinuses.
good.
Um,
Especially here is the superior sagittal, which maybe represent a drainage site. Good.
yes,
What else?
I would look at the mastoid air cells to see if there is any opacity there.
No, no, it's out of
Just to
our
finish the.
region. No, no.
Okay, no, no
You
problem.
suspected some sinusitis and the brain
Yes,
involvement in
yes.
between.
In between, yes, there is like a subdural collection. Uh,
Good, good. Extra-axial
so
collection. Very good.
yes,
Why I mentioned extra-axial, not subdural?
uh,
Maybe
be
epidural. Maybe epidural. I'm
yeah,
not sure. No problem. Okay. But
yes,
usually
yeah,
epidural can cross the midline. So it's better to term it extra-axial collection. Very good. So
if
sinusitis, extra-axial
yes,
collection,
yeah,
low attenuation
we're
area in the frontal lobe. What do you
suggestive of an
suspect?
abscess. So I think this is sinusitis with an intracranial extension and
Good.
possible abscess. I think I would want to give this patient contrast to delineate the abscess
Good.
in the brain. I would also, I think I would want to also, before doing that, look at the bone window to see if there is
Excellent.
any
Yes.
bony erosions.
Pertinent negative here. No pneumocephalus. Okay.
Yes.
Because if
Okay.
you see pneumocephalus, definitely we have a breach. Okay.
Okay. Yeah. Um, So looking at the bony window, sorry, I can't see any obvious erosion of the
Good. No erosion,
um
no destruction, no subcutaneous collection. Why?
okay.
Because if we see a clear destruction and subcutaneous collection,
Yeah.
we represent what?
Pot puffy
What's puffy?
tumor.
Excellent. Yes.
Yeah.
Collection inside, collection outside.
Yeah.
Breach, it's a frontal osteomyelitis. In a Pott's
Yes.
puffy tumor, the primary underlying pathology, it's osteomyelitis, it's bony rather than sinusitis. Okay. In the
Yes.
contrast,
So in this contrast enhanced images, I'm just going to focus on the abnormality I've seen on the brain. There is a bit of a peripheral enhancement and it remains hypodense, which is suggestive of an abscess, intracranial
good.
abscess. Also, I can see that there's
Abscess,
peripherally enhancing, sorry,
abscess or cerebritis?
I think there is peripheral enhancement. So I
Where?
think it, so around the hypodensity. Um,
Here and here, it's extra axial. But
Yes.
here, I'm not sure if we have
So
enhancing area here.
yeah. Okay.
So,
Yeah, I think it could be.
abscess or
Yeah.
cerebritis, choose one.
So the fact that it is a bit localized, I would still think it is an abscess.
Developing abscess, it's not abscess yet. Okay,
Okay.
it's developing. Okay,
Yeah.
I don't see
Okay.
a rim enhancing because if you see a rim enhancing, oh, I need evacuate, but cerebritis treatment and a different way of treatment. Okay,
Okay. Yes.
so
Yeah.
till now, no definite ring enhancing lesion in the brain parenchyma, but it's present
Okay.
mainly in the extraaxial. Yes, I agree, subdural or epidural, whatever. Okay, very
Yes.
good, my friend.
Yeah.
And patent.
Patent venous sinuses.
Good.
Um.
Patent venous, examined venous sinuses are patent.
Yes.
Good. Actually, I'm suspecting something else, but not sure.
Mm,
What? Why? There is some effacement of the sulci here.
mm,
Honestly, I suspect some subdural collection here, but it's
yeah.
okay. If I'm not sure, I can proceed into
MRI.
yes, yes.
Yes. I
No
think this patient
significant
is
leptomeningeal enhancement. Good.
enhancement. Yeah.
I'll see
And
if
yeah,
we
this
have
patient will be.
MRI. Yes, we have
Oh,
MRI.
okay. Fantastic.
Okay, let's
Uh,
see. MRI. This
This is a
done
T1.
post, yes, post intervention.
Okay. So I can appreciate that there is a extraaxial collection. I think it is subdural.
Yes, now it's
Yes.
subdural.
Yeah.
And
And
remember, after intervention, they evacuated you see
the,
some intervention here is done.
yes. Yep.
Okay,
Yep. And on the sinuses, it's ISO intense, but ideally, I would like to examine this in T2.
okay.
Um, yes. And there is um
Suspected.
suspected brain abscess here, or
Yes,
what I would
collection.
say is
Good.
collection. Yes, yeah,
Yes,
intracerebral
good.
collection. Yeah.
Good.
In the T2, there is the abnormality that we previously seen still stands. So there is ISO intense,
Okay, now the
hyperintense. Yeah,
aggravated condition, by the way, in the
yeah.
sinuses. Okay.
Yes. And there is a large or moderate volume subdural collection with mixed intensity of signal,
Yes,
which
good.
is suggestive of different types of material. It could be pus, it could be yeah.
How to,
Anyway,
what to do next?
so diffusion restriction would tell us, and if there is
Good,
central diffusion restriction on both of the lesions in the right frontal lobe as well as the subdural collection, it will be in keeping with abscess
good,
formation
good.
or pus.
In addition, very good, my friend. You detected
Mhm.
frontal lobe abnormality. You detected subdural and also
Yeah,
some areas cortical or subcortical high signal intensity.
high
In
intensity
the diffusion,
cerebritis.
oh,
So high in DWI. So I think it has marked diffusion restriction.
good, 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 my
Yes.
friend. And in the
Yeah.
contrast,
Uh,
oh,
it is peripherally enhancing, which is typical of collection or abscess formation.
yes. And
Um,
now it's evolved into definite
uh,
brain abscess. Okay.
yes.
So
The
it's
other
a
thing
complicated.
yeah,
Okay.
yeah,
Okay. So this is a
mm,
case of complicated
it sinusitis.
sinusitis.
Yes.
Okay. So
Yeah.
sinus infection can cause intracranial extension. Orbital infection can cause intracranial extension as well. Of course, this
Yeah.
is urgent neurosurgical, drainage, antibiotic, and. Sorry, my
Yes.
friends, your cases are difficult
No, no,
because
it's
you are
okay.
my friend. Okay.
Yeah, that's fine. Yeah. Okay.
Okay.
Uh,
Okay.
s- did I finish my cases or I still have one?
I'll
Mm,
give you this last one as a gift.
so-
Okay.
Okay. Okay.
Okay.
This
Describe.
is a
This is a spotter, my friend. Okay.
pot
25
puffy.
years old. Yes, yes. A fever.
Yes.
Just describe it.
Okay, so there is a frontal subperosteal collection as well as intra a frontal skull bone collection. Um, that is
The window is not ideal for soft tissue, so I'll give you soft tissue window.
no.
Yes,
Yes. So there is a soft tissue opacity or opacification, complete opacification of the frontal sinuses, and that
good.
is continuous with the subperiosteal and subgaleal collection, with erosion of the bone of the anterior wall of the frontal sinuses, in keeping with Pott puffy tumor or complicated sinusitis. There's
Good,
also
good.
yeah, the
Also
rest of the
erosion of
sinuses,
the posterior
the
wall of the
posterior wall.
sinus, no definite
Yes,
extraaxial collection, no definite hypodensity in the brain
brain.
substance. However, in
Yeah,
my routine practice, I will check bone window and contrast study to rule out any intracerebral affection. So it's
yeah.
osteomyelitis. Okay.
Osteomyelitis. Okay.
Yes, Pott's puffy tumor.
Yeah.
Okay, my friend. Well done, ya
Thank you very
boss.
much.
Well done.
Thank you very
Well
much,
done.
Dr. Ismail.
Welcome,
Allah يخليك.
welcome, welcome.
Thank you.
Thank you.
السلام عليكم.
Okay, Dr. Ali, candidate 6 is ready.
Assalamu alaikum, sir.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
Fine, sir.
Okay, let's see this case. Neck pain and numbness. Okay, and dysphagia. What do you see?
This is the X-ray cervical spine and lateral view of the neck, in which lateral projection I can appreciate there is a prevertebral soft tissue thickening, which
Good,
is extending from C4 to D1 vertebral body.
good.
However, there is no nerving of the airway.
So
At the
the
upper
so
column
the
of,
soft tissue thickening extending from 1, 2, 3, 4. This level, for
yes,
example, or 4, 5.
yes, yes, sir.
Okay.
And there is a vertebral body, there is straightening of the cervical spine, and there is a reduced intervertebral disc space
Where
at 2, 3, 3, 6, 7, and C is 71 levels.
this
Yes,
these
sir.
levels?
Yes, sir.
Okay, just
As
I
compared
will
to the upper airway.
25. Any disk
Yes.
space is not accepted. Even in the normal location of degeneration, yes, any narrow disk space is not accepted in this age group. Very good. What else?
There is erosion of the C3 vertebral body
Excellent.
along superior end plate.
Excellent. I will make some zoom. In my routine practice, I will make some zoom to help you. Very good, my friend. You see
There is
erosion
subtle
of the,
erosion and lucency, yes, along the
yes,
superior margin.
yes. So narrow disk space here. And also, what about the anterior cortex?
Yes, it is also slightly eroded and lucent.
Excellent. So erosion of the anterior cortex with narrow disk space, erosion or nearly destruction of the anterior cortex and superior end plate. Soft tissue thickening is not starting here, my friend. Actually, it is not this one. It's starting. Oh, all this. You see?
Yes,
Because the patient has some degree of obliquity, so it's increased also diffusely, not abrupt, it's diffusely. Very good, my friend.
so
So
it's a multifocal disease process. It can be the
excellent,
infective spondylodiscitis, which is involving the multiple levels of the spine. Next, I
good.
would advise CT or MRI cervical spine for the further evaluation.
CT for bony extension, MRI to rule out any epidural collection,
Collections.
which
Yes.
is responsible for the numbness or pain felt by the patient. Okay, this is regarding the imaging, and of course, urgent neurosurgical referral. Okay,
Yes, sir.
drainage of abscess and culture and sensitivity. Very good, my friends. What else? Is this enough? No, it is not enough. You said multifocal, but you didn't tell me a specific diagnosis. Skip
The,
lesions. It's not multifocal and adjacent to each other. Skip lesions. It means subligamentous spread.
Yes, sir.
Huh?
Yes.
Diagnosis.
Tuberculosis.
Yes, my friend, TB. I want to hear this words. It's very important. Why? Because I will indicate imaging of the chest.
Chest. Yes, yes.
Yes, and also extended imaging of the spine. I want to rule out the other areas of the spine. Maybe the infection is not confined to the cervical spine. I need to extend the imaging to the dorsal spine as well. Okay, let's
Okay.
go back to this case. Unfortunately, with such case, perivertebral soft tissue thickening take antibiotic. This is what happened, and after 1 month of antibiotic, it's missed. Usually in practice, missed. This bony changes because it's subtle. These subtle changes missed, usually missed in practice. After 1 month, what happened, my friend?
These are the T1 stars. These are the T1 post contrast images. I can appreciate multiple oblong shaped peripherally enhancing collections, which is extending from the C2 vertebral body down to the thoracic spine, which is causing destruction of the multiple vertebral bodies with involvement of the intervertebral disc spaces. And there is subligamentous spread
Excellent.
elevation of the interior and posterior longitudinal ligaments. Posteriorly, it is causing marked compression over the spinal cord at this level. I would like to see the axial view to see the further extension into the spinal cord and compression over it.
Good.
However, the
Good.
spinal cord retrieves normal signals in my routine practice. I would like to review the rest of the
Spinal
images.
cord, the normal signal, okay, from T1 or T2, the area of encephalomalacia. I will give you Dracula. Okay. I need T2, my friend. Okay. I need T2. Okay. Here,
Yes, sir.
epidural, enhancing epidural component. It's part of a
Yes,
phlegm
sir.
rather than abscess. Okay. But the signal, I need to detect signal abnormality also on T2. Any
Yes, sir.
increased signal abnormality, it's encephalomalacia. And this is highly emergency. Effacement of subarachnoid spaces, CSF here with some artifact, okay? And this enhancing component in the T1, I need urgent
Urgent
neurosurgical,
neurosurgical.
yes.
Yes.
Evacuation also correlated with ENT, evacuation also of this abscess, drainage, and imaging of the chest again. You see, it's very complicated case, and from plain radiograph, you remember the starting point? Prevertebral soft tissue thickening.
Yes.
Just the prevertebral soft tissue thickening. No, any case like this, any case, prevertebral soft tissue thickening, please, my friends, comment on the bony skeleton. Rule out any spondylodiscitis. What about here? No significant disc narrowing, but definitely rarefaction, destruction. Okay, sorry, my friends, it's a difficult case. Now I will give you an easy case. Same age group, fever, sore throat. Do you want to take the control?
Yes.
Okay, ask for control. Okay, proceed.
Okay. I'm provided with the CT paranasal sinuses and the base of the skull.
Neck. Okay.
Okay. First, I will scroll through the whole stack of the images, then I will comment.
Fever,
I can
sore
appreciate,
throat.
yes, yes, I can appreciate there is a significant parapharyngeal soft tissue thickening in the area
Excellent.
of tonsils. Bilateral tonsils are enlarged, and in the these are causing marked narrowing of the airway. So it's an surgical it's an emergency. I would urgently inform the head and neck team.
Wait, my friend. Wait, step
Yes,
by
sir.
step. Step by step.
Yes, yes.
This non-contrast
In and
study.
in, yes,
Okay?
sir. In the right tonsil, I can appreciate some
Good.
hypodense area, which
Excellent.
I am concerning for the abscess formation. So I would like to see the post contrast images for the
Yes.
confirmation of this my findings.
Excellent. So step by step. Yes,
Yes, sir.
the area of the palatine tonsor is thickened on the right side as compared to the left side.
Yes,
Parapharyngeal fat is effaced on the right side as compared to the left side. Also some smudging of the parapharyngeal fat. So definitely we have a right-sided pathology. Okay, maybe subcentimetric lymph nodes can be seen as well. With the given history and age, I'm suspecting inflammatory process. I'll recommend a contrast study which revealed.
On post-contrast enhancement, there is an peripherally enhancing collection is appreciated in the palatine tonsil, which is consistent with the abscess formation. Left palatine tonsil is also
Very
slightly
good.
enlarged in size. At sub-centimeter cervical lymph nodes are
Good.
appreciated.
So diagnosis, because I'll give you another case. Diagnosis,
It's palatine abscess.
it's called peritonsillar abscess. Okay.
Okay, sir.
Peritonsillar. We have two abscesses in this area that's common. Retropharyngeal and peritonsillar. So this one is a
Peritonsillar abscess.
peritonsillar abscess. Okay. I'll give you another case, but this one is easy, inshallah, not tough. 50 years old with fever and swelling.
Okay. I'm provided with these CT neck post-contrast images. First, I will scroll through the whole stack of the images, then I will comment on the finding. I can appreciate ill-defined, bizarre-shaped, hypodense, peripherally enhancing collection in the sublingual space. There
So
is
in the mouth floor,
associated
very good.
yes, floor of the mouth in the sublingual space, and there is some associated surrounding fat standing. As the patient has history of tooth extraction, so I am concerned about the possibility of Ludwig angina in this case.
Excellent,
Uh,
excellent. And
there
together
is no
with
extra.
some reactive lymph nodes in the both
Yes, multiple
submandibular
enlarged lymph
region.
nodes in the
Yes,
bilateral cervical regions. There is
very
no
good.
extension into the submandibular space, and
Good.
rest of the structure seems normal. So it's
And
likely
in my
keeping
routine
in the history
practice,
of the patients.
I will check the bone window. Why bone window? You remember the tooth extraction, so I need just to
Yes,
rule out any underlying osteomyelitis as a possible cause. Very good. And also patent vessels, any infection in generally, patent veins. Okay, rule out any venous thrombus. Excellent, my friend. Diagnosis and management.
I would urgently refer this patient to the ENT team
Okay.
for the further management for the incision and drainage of this collection.
Okay, okay. EMT or pharyngeal, yes. Drainage and antibiotic coverage, yes. It's abscess in the mouth floor, so it's called Ludwig angina. Excellent, my friend. You see, you are the big boss, mashallah. Okay. Any remaining candidate, Dr. Ali?
No, we finish our list. We finish
Okay,
our
okay.
list. Yes.
Okay, I'll give you, because you are the big boss, I'll give you one last case.
Okay.
Okay, let's see. I'll take the control. Just last candidate, please. I will take the control
Yes.
back. Okay. Okay. This patient, middle age, fever, dysphagia, septic patient. Let's proceed.
Yeah.
Dr. Ali, ask for control.
Yes. I will ask. Yes.
Okay.
So I'm scrolling through chest CT scan, axial or neck CT scan, axial images with IV contrast. The patient is septic. I will scroll through the images until the last cut. Then I will come back to my observation.
Okay, enough for this. Yes.
Yeah, for it is for the neck. I noticed that there is peripheral enhancing lesions noted in the left internal jugular vein.
Excellent.
I'm now scrolling. I also noticed that there is also another abscess collection manifested by peripheral enhancing, also seen in the left tonsillar area.
Yes. Point to it for our younger colleagues.
Yes, this one.
Yes. Peritonsillar abscess. Very good.
Peritonsillar
So
abscess.
it started as a tonsillitis, complicated with abscess, and point to the jugular. Yes, the jugular is non-enhancing with enhancing rim, the thrombose. Very good.
Yes.
But the patient
So
become very septic.
yes. So I will continue to see the rest of the jugular vein pathway. I can see
Yes.
that there is multiple filling defects and also involving the left external jugular vein.
Excellent. The
Both of them
draining vein into
appears.
the jugular also thrombose. Very good. Very good.
Yes, and here I can see that there is another foci of collection, and the jugular vein appears dilated, and here it is
Actually,
compressed.
it's not collection, external jugular also, or anterior jugular. You see,
Yes,
ring enhancing, and it's oblong. So it's anterior jugular. Very good.
yes. Here I can see that the jugular vein appears occluded and thrombosed until its terminal end.
Good.
Otherwise, the brachiocephalic veins and subclavian veins appears patent. The left,
Excellent.
so the right internal and external jugular vein appears patent. So my impression for this case is peritonsillar abscess complicated by thrombosis within the left internal, external, and anterior jugular veins, representing Lemierre syndrome.
Just give me the mouse. Why give me the mouse to draw this one? Okay. And
Oh,
this is Donald Trump. Okay.
yes,
Why?
yes.
Why, my friend? Okay. Because you didn't comment on the upper chest cuts.
Yes. Okay.
What happened in Lemierre syndrome? It's a
Yes.
septic thrombophlebitis of the internal jugular that can lead to,
That can lead to,
yes,
I
comment on
forget.
the chest,
Yes,
septic
I can see.
emboli
Yeah,
in the chest. Mm.
septic emboli. Yes, I can see that there is a peripheral lesion seen within the right lung, and also I can see that there is pleural thickening and
Yes.
in the left side. So in this case,
And
I
also on
want
the
to
left
see.
lung, do you see any
Yeah,
nodularity? Yes.
yes, here.
Okay.
In this case, I want to shift this into the lung window.
Excellent. And any lymph node, any reactive lymph node in the mediastinum?
Yes, there is a lot of
Okay.
mediastinal lymph
So we
nodes.
have mediastinal and chest infection, and here in the lung window, we have some nodularity. I know it's neck study, but you will ask for chest CT scan. You will see assess these nodules and detect any cavitations, whether cavitating or no. With the clinical setting, definitely it's septic emboli. Okay. So antibiotic coverage and anticoagulant and close observation and hospitalization is needed. Okay, thank you, my friend. Thank you, Dr.
Thank you.
Ali. Well done, well done. And thank you really for the organization process. Thanks to all our colleagues. Today I tried to cover some head and neck emergencies.